there must be a reason to it. We need to take a look what are some of those key things, and maybe from the reports that you submit into NRLS, they are able to get more information and data out of it, and what next to do. This is why learning healthcare is so good. This is done in the US by our PSO organization too in the United States. So it's the same thing. So we're not saying don't learn. We still need to learn from the errors that we have. That's very, very, very important because we need to understand what happens, especially when you bring in new treatment, new technology, new medication, new processes. Those are things you need to have a super magnifying glass looking at it because it's very new. Nobody has an experience of, let alone some doctors will not have enough experience to use those new things. Who would have experience to deal with the adverse event? If you don't even, you're just learning to use the new things, who else would have experience to deal with if there's an adverse event, and what kind of adverse event? There will be nobody. So we have to be very cautious, and if we can continuously get more information and learn from the past, so there are things we can do. For example, if this new technology is cannibalizing an old technology, what was the adverse event we saw with the old technology? What was the problems that we saw? And potentially, we have to create a hypothesis about what the new technology would cost to us. So that's the thinking. That's how we want everyone to start thinking in terms of a total system approach. You don't just think about today and what that is. You have to think about it from all the circumference. Think about what I like, the word that I always like to use, contributing factors. You need to understand the contributing factors. If you do not understand them, you will not be able to manage and handle them. That is the meaning of total system that you have to think about. Not just specifically on one thing, but you have to think about everything else that circumvent the actual technology or drug or treatment or process that you create new. Last but not least, and I think about one more quadrant within the total system safety, is about patient-family engagement. Many physicians has recognized, and many reports has been published, that if you engage your patient, you get better outcome in terms of the treatment. You get better compliance in terms of their treatment. Patient outcome oftentimes improve. Many of the published report has shown that. Now, because the world is lacking of hospital bed and lacking of healthcare clinical workers, we are trying to use new concepts such as send patient at home. People say telemedicine, hospital at home. All that new concept is just not new technology. If you take away the word, right, today and yesterday and last year and the year before, you also send patient home. When you don't have enough bed, you choose the patient with less risk, and you still have to send them home. What's the difference between that work, which has no name, and now people call it hospital at home? The difference is, now you have to extend the care all the way to the home. In the past, you just send the patient home, tell them to be careful, take care of this, eat your medicine, remember to come back for follow-up every day, change your dressing every day, things like that. That's what you say to them. You still ask them to come back, but you still send them home. So the big words that people use today in the world of hospital at home, the difference is, when you use the tagline or the name hospital at home, the concept change. You have to extend everything in terms of your care at home, i.e. your physicians and nursing has to visit and actually be able to provide the care in the comfort of the patient home. To support the theory, many papers has been published and say that patient gets better and recover better in the comfort of their home and with the comfort of their family members. So that's true. Many report has published that there is a positive outcome to care treatment. So because there is a positive outcome and there is a strong need to send people home because we don't have enough bed, that is why we have to think about what is our concern. concern for the workforce, and concern for our patient and their family at home when we adopt this new model. Have anybody thought about what is the challenges and concern when you adopt this model? Oh, no big issue. I get them a physiologic monitor, hook them online, and then send the data live to our hospital. Our hospital will be able to monitor their vital from our hospital, and patient is at home. We can monitor that. Then we will teach their family members how to care for the patient when they are at home. Just simple two things that I brought up. Number one, how do you know if the family member can be taught? How much can you teach? What symptoms can you share with them when they are there? And what happens if the vital drops and there is an alarm sound and they don't even know how to read the vitals? What do? Oh, they call us in the hospital. So you're basically having a caregiver just looking out for any alarms. That's it. But there's no care. What care? You're just asking him or her to be at home. So think about the challenges. What I'm giving you as an example is to instigate your thoughts, to think about potential challenges when we use those new concepts and those new approach and technologies in our healthcare setting. It will bring you different challenges, and those challenges can manifest itself and become an adverse event to you. And that is why we have never been able to reduce all our adverse events, because we kept, that's a good example or actual example of us introducing new things to our healthcare, and at the same time having that high potential of creating adverse event for ourselves and our patient. So basically, the total system approach are asking you to be thinking more and beyond a specific topic of issue. And the most important thing, you don't only think about it when an incident happens. You have to think about it proactively. You cannot be thinking about it only when an incident or a challenges already happened. When an incident happened, and this is where I don't like, because before an incident happened, we share and we tell. But when an incident happened means somebody's mom, somebody's father, somebody's sister or brother, son or daughter, or loved one has already been harmed. So that is the reason what we are trying to do. All of us, all of you here are also trying to do. We are trying to reduce that kind of incident and that kind of sad condition. That's why we are here. And I'm grateful that there's so many of you here, because there's so many of us who wants to do better for our healthcare community. Right? So it requires us to think more proactively and act more proactively. Every time you try and do something different, study the pros and cons. Find the actual potential issues that is going to happen, and then we solve them. Right? So that's what total system safety is calling. And I have already said earlier, it may sound like I'm already doing this in my hospital, I'm already doing this every day. Yeah, but now when I explain it, I was hoping that you would think a little bit deeper of what I say. And also the word proactive, not reactive. Okay? So how do we achieve? How do we actually get there? Many people have asked, yeah, the concept, the framework looks very good, the idea is very good. Eric, how do we actually do it? It's easy to say and sit here in front at the podium or the stage trying to share a concept. How do we actually do it? For those who were, I see some familiar faces from the Northern Territory in Chiang Mai when I was there 2 weeks ago. Thank you for coming back, and thank you for sharing your cases. I'd like to thank them first. We spent 2 days or so talking about areas where we need to be focusing on and how we can actually do it. Now, I only have a few hours with you guys today, and we will try our level best. I hope you can get as many information as possible. And that is why I encourage people to ask questions if you are interested to know more. So how do we do it? First, you need to have a framework. You need to understand the big steps of what we need to do to achieve that. Okay? All the slides are with HAI. You can get these slides from HAI later if you want to. Okay? So they have my slides here. So the first area that I'd like you all to think about, is identifying area of concern. So in order to think about where my workforce safety issue is, what is happening to my culture, is my leadership supportive, do we have enough guidelines and policies available today? Do we have enough human or the right kind of people working on things? Is our competency or our knowledge and the right people doing the right thing? So if you do not identify your area of concern in those the quadrants, then you will have a big challenge. So you have to identify the area of concerns. Use assessment tool, and don't do it yourself. Do it in a team. Develop, once you identify them, you will be able to do a lot more things like stratifying what are the priorities and all that. Then you design a solution or a preventive strategy. Okay? I've been told I need to rush faster. Then once you have the strategy, then you have to implement. And now, of course, like every other things that you do, you need to monitor. Come up with what we call the actual measurable outcome, both quantitative and qualitative. Okay? So that's an approach to how you start developing a model for total system safety. So I'm going to skip this few. These are really the details of what is in the quadrant. You can see from the slides later as well. In the interest of time, I'm going to rush through a few things. This one is in there. Develop error prevention strategy. I just want to highlight this tool. When you develop a strategy, how do I prevent the future harm? There is many models if you will research it. This is just an example model. A model that talks, this is from our ISMP, a model that talks about what is effective, less effective, what is an effective strategy. Okay? So you can see that there is a model that we developed. Example, training, education program is least effective. So we do a lot of education program and we think it's one of the best strategy that we can deploy. But our study and research has shown that, and I totally agree with this because I've also experienced this, educational programs are least effective. There are more effective strategies that you can think about. So I won't go into that detail, but it's one of those things that you can use. There are many different tools and models to help you go through all those steps. Even in implementation, there are many different approaches and tools that you can use to develop those work. And monitoring, people ask, how do we monitor false prevention, for example? How do we monitor? How do you actually look at reducing? In the slides that I have, there are examples from culture, plan action, and a time frame of 5 years, what we want to do, and how do we achieve them. This is how you come up with a monitoring parameters. Some people say it's a KPI. I don't like to use the word KPI because, ladies and gentlemen, we don't work in a factory. Key performance indicators are primarily designed for the factory. We need to look at the goals, the outcome of our patient, and along the way, what are some indicators we can use or criteria we can use to actually measure those things. Those are the important ones. So this is how you should set these goals and those plan that you want so that you can measure them. Monitoring, and then sustainability and continuous improvement. If you have reached the stage where you have completed a cycle of monitoring, then there must be enough sustainability, and you cannot stop. If you have already a program now, that doesn't mean it's finished, my job is done. The difficult work is over. Now we just monitor. Every year we just audit, finish, very easy. Wrong.